Well, welcome everybody to First Presbyterian's Insight class, where First Presbyterian's identity, faith, and values meet today's world. During the pandemic, we've been doing our Insight classes over Zoom and recording them for people to watch after the fact using YouTube. We have a hard stop at 9:50 this morning, and because that's when because the church is streaming its services starting at 10, so it gives people a chance to transition and get to the and get to church. We are today ending a series on ethical and moral choices at work. We've had many very interesting speakers. I've invited an oncologist, a middle school principal, an executive from a defense aerospace company. Many people have come to talk to us about their work and ethical and moral considerations in their work. And I found it just fascinating. And we are ending on a very strong note because we have Chad Proctor is joining us this morning to talk about moral and ethical considerations at his work. Many of us know Chad. He is a member of First Presbyterian, and his wife Amy and children Olive and Sydney are members. And he is a nurse practitioner with Mercy Care. He's been a nurse for 20 plus years and a nurse practitioner for the last 3 years. He specializes in palliative care and hospice. So he's just a great person to have with us to talk about this subject. So Chad, welcome, and I'll just invite you to take it away.
Thanks, Matt. Welcome everybody. Good morning on this beautiful white morning. So normally I'm sitting here, my face is a little more dulled usually, but sitting here in the office, but the snow is reflecting the sunlight and it's kind of tranquil. It's kind of nice. So, and we talk about tranquility in life and whatever is going on in life. And I'm going to be speaking a little bit about the kind of the role I do at Mercy and in healthcare in general, and palliative care and hospice. And I was telling Matt, I'll give you guys a little bit of a spiel I do to my patients or with my patients and their families, because a lot of times they don't understand, or they've gotten misinformation on the good old WebMD because they Google, the magical Googling leads patients astray sometimes before they get to their doctor's office. So as Matt introduced, I do nurse practitioner work in palliative care and hospice at Mercy. By training, I'm a family nurse practitioner, but over the course of the years, I've become, I guess, not pigeonholed, but specialized in palliative care and hospice. So if you Google palliative care and hospice on the internet, there are a lot of synonymous terms and come up in articles, and they use those terms interchangeably when in fact they're not. So palliative care is imagine a big umbrella, and under that are pillars of home care, home PT, pain management, chronic disease management. Those are all pillars, including hospice is a pillar, because palliative care can lead to hospice. It doesn't have to, but it can. And then I do hospice too, and that's, with patients choosing not to be aggressive with their healthcare process if they have terminal diagnoses or severe disease processes that eventually are going to, have them pass that are uncurable, and we go from uncurable to a symptom management process. So I talked a lot about patients, and they ask, what am I here for? Or why are you seeing me? I do a lot of pain management, whether it's due to disease or surgery or accidents or post-surgical pain that they didn't get full relief from. And I tell patients, well, your cardiologist focuses on your heart, your pulmonologist focuses on your lung. My job is to come in and I don't keep stepping towards you. I take actually my team and I take a step back, and we're one of the few teams that we have a social worker, and her and I, there's 4 of us nurse practitioners that do what I do. We have one that predominantly works inpatient in the hospital. That's all she sees is inpatients, and feeds that pipeline for when they are discharged, or their outpatient community members who have frequent hospitalizations. And she sees them when they're inpatient. But we have a social worker who supports these patients as well. And my job is, I look at a patient not only physically, but I look at them, I kind of take a step back and we look at them emotionally and psychologically, physically, and spiritually. Because patients might be okay medically. You know, they have a lot of specialists between their cardiologists and their pulmonologists and their kidney doctors. And, you know, they're getting to those appointments and they're going to a lot of appointments. They may or may not have social barriers. And our social worker and myself will work a lot with those patients. But some patients are lost spiritually because they have so much going on in their life that pillar is weakened or crumbled. And I don't really speak of religion because, you know, we're pretty diverse. You know, I work for a Catholic entity. Here I am, a Presbyterian working for a Catholic entity. We do prayer. Patients are very devout with their religion. What other Protestant or Christianity-based religion is the predominant, but I run into other religions as well. So then it's a lot easier, instead of focusing on religion, we focus on spirituality. You know, and just a refresher, you know, what is spirituality versus religion? You know, coming here and seeing church friends and church family, that's, you know, is that spiritual? Yeah, it is. Because, you know, spirituality is expressed in, you know, beliefs and values and traditions and practices. And however you choose to practice your spirituality, we try to meet patients where they're at and try to prop them up and become pillars in their life. And that's something that we value, and that's one, I guess, piece of the pie we look at with patients. We directly ask them, do you have are you connected with spirit? Are you spiritual, or are you connected with a faith service? Is kind of the nomenclature we use. And because some patients, as we know, some of our church family members don't frequent church very often, but they're still very connected to the church, even at First Presbyterian, and they're quite spiritual. And that's one pillar of life and component of healthcare that we have to look at and we want to address. Because if I can fix or help get there, I use this adage a lot, patients are a ship, and I'm part of that crew, and including their family members and the healthcare team. And we don't know where the ship and the course is headed, but my job is to keep them off troubled water. And I'm trimming their sails all the time to adjust their course, to keep them the best quality of life that they can. And that is through physical symptom management, predominantly, whatever symptoms they're having, shortness of breath or pain or poor sleep, or maybe they're having psychological distress. They've got horrible anxiety and depression from their disease process, and or they're having social issues. They don't have a support system, or their support system is broken. They have family members, but they're disconnected. So our social worker does a lot of support and work and counseling with that. And interwebbed in all of that is spirituality. We used to have a pastor on our team, halftime. And how ironic, by training, she was a pastor, but she was also really good registered dietitian who went back to seminary later in her life, but she really valued being a nutritionist. So she stayed in the Mercy system, but she departed our team. And unfortunately, with COVID and budgets, and we've lost our pastor half-time position. So we've kind of had to pick up the slack a little bit. Mary was our former pastor. You know, she did a lot of spiritual assessments and really did some counseling, kind of overlapping what the social worker has been doing. So we are missing that, but we're able to get into that realm. So another, we do have some brief assessment tools, and it's, you know, we're not sitting down with pencil and paper. This is, and assessing a patient. This is sitting with dialogue and just talking with patients. And we kind of go through and see where patients, you know, I'm not tricking them, but I'm asking them questions to see where they're at mentally and emotionally and spiritually. And I'll ask, you know, are you connected with the church? No, I'm not connected. Okay, so, you know, they don't have a real church family, but that doesn't mean they're not spiritual. So then, and it also, varying degree is where are they at in their disease process? Are they a brand new cancer, you know, a metastatic severe cancer diagnosis? Because if they're in the very beginning stages of that, their mindset is a lot different than if they're at the end stage, or they've been dealing with chronic pain for 20 years or 6 months. And then, you know, we ask question, is religion or spirituality important to you to help cope with this? Yes or no, you know, and that helps direct the question. It's kind of a little bit like a Venn diagram. These bubbles overlap each other, and the answer yes or no. And then, are you at peace? Okay, that will direct the question. And then, are you having any spiritual pain? Because maybe patients are slowly physically getting better, but maybe their family and support system, whether it's biological or non-biological family, is disrupted. And are you experiencing spiritual pain? We use that term. Are you experiencing spiritual pain now? And how would you, you know, how do you rate your spirituality? Is it a 10 of importance, or is it just a 1 occasionally in the back of your mind? Because that really helps direct our care and the care and service delivery that we provide. And we deal a lot.
Could I ask a question?
Yeah.
If somebody were to say that they were a 10, what kinds of services would you be providing them that you might not provide them if they're a 1, or vice versa?
Right. So, you know, pre-COVID, we would immediately call the church office and ask for it and get directly, and I spoke directly to church deacons or assistant pastors, or they may, you know, with HIPAA, like for example, Heather may not know that she might know that a patient X is in the hospital, but she doesn't know that they're spiritually really kind of a mess and need that support right now. So I'm a bridge, you know, and I've done that multiple times, spoke directly with pastors and assistant pastors and said, hey, you know, I prayed with them and we spoke pretty openly, and they're kind of I don't want to say a mess, but they need a pillar in their life right now. And they're like, thank you. We knew they were hospitalized. We knew they were ill. And then, you know, we all tiptoe around respecting space. Patients need to recuperate, but sometimes, and you don't want to get too many cooks in the kitchen, but sometimes swooping in on patients is good. It's a good thing, and it can be a good thing. Post-COVID, I've been doing a lot of just supporting and listening, you know. Listening is a good quality. You can say a lot without saying anything, and just allowing patients, if they're isolated, which we've been encountering. Patients just need that emotional support, and it kind of helps fix, per se, that spiritual support. They kind of go hand in hand. So that's how we, if somebody rated that really high, that's how we would do it. Or, you can't do it deacon visit in person, but they need to be called and checked in on. So, I have a lot of patients who use Stephen Ministries. I don't know if you've heard that support. It's type of through the Lutheran churches, and we'll call them like, you need to call this person. Well, they're on my schedule to call next week. No, you need to call them tomorrow. They need that support. They need more hands-on, and nobody's been opposed. They're like, okay, thank you. So we appreciate that. So.
Thank you.
And there's all sorts of spiritual assessment tools. I kind of stay away from those. Those aren't my specialty. So it's just, I kind of view it as a piece of the pie, and kind of they go hand in hand. If somebody is doing better physically and emotionally, spirituality follows that a little bit linearly, and we can get them feeling a little better. So, and their spirituality can go a little deeper when they're physically feeling better. Because first, if somebody's in acute pain, not feeling well, their spirituality is usually, it's going to be poor, and it's not going to be, it'll be important, but not the main focus, because I need to get them physically feeling better. And their immediate acute distress I need to fix. So, if somebody has end-stage lung disease due to cancer, or, 40 years of smoking, and they can barely breathe and not get short of breath talking, me speaking on their spirituality and trying to do a spiritual assessment isn't the time to do that. So I need to get their symptoms managed. And then when patients have disease process, that progress, and then we slide from from a palliative care to a hospice discussion, because my number one job, and I've never had a patient disagree with me, my job is to keep you out of the hospital, whether it be the ER or recurrent hospitalizations. Because if I can keep you out of the hospital, that means your quality of life is improving, and we can manage your symptoms at home. I've never had anybody say, I don't really want to stay at home. No, they all want to stay at home, whatever that quote home is. Is it assisted living? Is it with their daughter? Is it with their son? Is it in their own home with family coming in, or they're having private duty coming in? Because I want to keep them at home. And if I can get them feeling better, or their disease process is worsening, then and it's not curable, then we slide into a hospice discussion, and that's okay. And sometimes we talk a long time about hospice before they actually enroll in hospice. And then when hospice comes in, hospice swoops in, and they also have their own social workers, and they also have their own hospice chaplains. And a big proponent of my job and my thinking and process is to get patients into hospice sooner rather than later, because hospice services greatly benefit patients. And sometimes the chaplain services within hospice team, they do some good work, and they've done some necessary work, and they've helped patients resolve some, what we call spiritual distress or emotional distress. They've carried some, quote, baggage for many years in their mind, or they're scared, and they help them work through that, because hospice team is really on top of patients, and we can usually get their symptoms managed pretty quick, their physical symptoms, and then that allows some emotional and spiritual symptoms and resolution to get fixed, so they're more at peace. And they kind of go hand in hand, hospice and palliative care, when that comes, per se. Does anybody have any direct experience with palliative care? I know a lot of people have hospice experience, whether it's be a loved one or through church or work. Or is there any immediate questions I can answer? Or comments?
Yeah, I've had experience with that, and actually both parents, and one of the heart-wrenching things is when they're not having anything to eat or drink, and to
Yeah.
live with that, and to know whether or not you made the right decision. Because there's always that ray of hope, maybe something could turn around, and then, because basically they're kind of starving to death, I mean,
Yeah.
that's kind of a graphic truth, but it's really, really difficult to see and go through.
That is,
Very.
yeah. And I encounter that a lot where, the patient's at peace and they've made that decision to enter into hospice but their loved ones, the families, and I encounter that a lot, Leland, where they're like, well, they're not eating or drinking. And I'm like, well, we're listening to their body, and their body is telling us what to do. And that's, imagine, patients in hospice, they sleep a lot longer, they don't eat, they don't drink. They need their rest. And when they're awake, they might take some sips and bites, but they don't need the sustenance that we need. And that's okay. And that's unfortunately, that's a normal death and dying process. And we think patients are starving, but they just can't. It takes a lot to eat and to process that. And patients just can't handle that. So, and Leland, you brought up a good statement. It's hard to watch that. And patients, family members, I hear like, oh, did we make the right decision? I'm like, well, you did, but I want to take that off your shoulders of making decisions, because we need to look at your loved one to see, is they're guiding the care. They're not telling us, but their body is showing us that now's the time to not be aggressive and to offer peace and comfort for them, because their disease process is so advanced that you don't need to make a decision. They're telling us, and the time's showing us now. So, and that I use that a lot to help take that away and off of adult children's shoulders. They're like, oh, we don't know when to make that decision. And I said, well, you don't really need to make the decision. Mom or dad is kind of telling us now. It's okay. Let us come in and help. And because going back to the hospital isn't that going to be beneficial. And a little mini case study, I'm working on that right now. A patient, he's elderly, and he's been on dialysis for many years, and he's tired. He's physically and emotionally and spiritually tired of dialysis. And he and his wife, some days they want to enter into hospice and be done, and some days he doesn't, or she doesn't. And I'm on this journey with them, and I don't force anybody, but I tell him, and I'm very open, I'm on this journey with you, and he's going to tell us when, and his body's going to tell us when it needs to be done. Because his wife's very emotionally and spiritually, she's not quite there yet. And when we say we're not quite there yet, haven't come to full grasp of letting go. And I said, you don't need to let go. We just need to change. This is a new life chapter. We're entering a new life chapter, and that's okay. And I would rather have 3 good months of quality of life than 4, and instead of trying to squeeze out a 4th month of having yuckiness or uncomfortableness or distress. And that is a lot better quality and than quantity. And we get into spiritual and emotional, and those all get dumped. Physical, when we're in that realm of end of life process, we get that all dumped into the mixing bowl altogether. Because and we've talked very openly about that and support patients. And
Chad, my mom is on palliative care right now, and your comforting words and comforting way that you're speaking about it are reminding me of when my brother and I had a conversation with her doctor.
yeah.
to make this change. And it's been about a year that she's been on palliative care. And I had a lot of the same questions and concerns. But she is living in a place down in Austin that's it's kind of like Cottage Grove, and she's in the memory care ward, and she's physically in pretty good shape, but she has dementia, and she forgets that she can't just get out of bed and go to the bathroom, so she falls a lot.
Yeah.
And so what was happening was she would fall, she would crack her head. She's cracked her head, I can't tell you how many times, and and so then that was a trip to the emergency room, staples or stitches or glue or whatever in her head. It was an MRI to make sure there wasn't internal bleeding, and and then an ambulance trip back to where she was. And one of those times my brother was out of town, so there wasn't even anybody from the care center where she lives who was with her. She's just in this emergency room with the ER docs and nurses and what have you. And every time it's the same drill. Every time they stitch her up, they find no internal bleeding, and then she's back where she was. And it's hard to think of doing nothing, but at the same time, that just made me feel so awful that she's there.
Right.
And I couldn't be there. My brother wasn't there. She doesn't know who these people are. So it's been actually a comforting feeling to know that we have made this decision, that we don't need to put our 92-year-old mom with dementia through that
Correct.
anymore.
Martha, that's a prime example of, I have to be careful on a Sunday morning with a church group, but the F word is very prominent in my world, and that means a fall. And falls happen a lot. And I encourage you, if your loved one is in the state of Iowa, this is a little sidebar. We have a form called an I-post. I don't know if anybody in Insight has spoke of that. I fill them out. Your physician can fill them out, and you can do it for a loved one. And it's another further clarification of your code status, a DNR or comfort care, and it, especially if somebody in facilities, they usually require them, or if your loved one's at home, if mom or dad is at home, and it's a state-based form. So Des Moines, Waterloo, Sioux City, wherever you go, the form's going to look identical, and it helps communicate to emergency personnel that patient's wishes are. And we sign them and fill them out and put them on the refrigerator. And that way emergency personnel know what to do. And I do that sidebar because that doesn't mean you can't not go to the hospital, but we're not going to be aggressive and go 100 miles an hour with sirens for someone who their quality of life is not going to be good. And we do that because patients think of hospice and palliative care of, oh, I'm done. This is the end. I'm like, no, it's not the end. If you get bronchitis, I'm still going to give you antibiotics. If you have a sinus infection, yeah, we'll treat that. But if you are getting congestive heart failure, we're not going to send you to the ER to get admitted to the cardiology floor to get that worked up by a cardiologist. We're going to manage those symptoms because we already know that your heart is not in good shape. Dementia is a huge diagnosis that I deal with day in and day out. And that is a booger to deal with, and it affects everybody so much, and it's tough. Personally, I've done that. We lost my mom to hospice with dementia. She was at home on the farm after my dad died, and then we moved her to town, and then moved her to assisted living, and then she was in a memory care area, and then she got a pneumonia, and that's kind of what did her in, but the disease process was progressing at the same time. So having patients fall is really troublesome. And we try to, I'm not there working 24/7 with facilities, but I try to talk with facilities and say, hey, what's causing these falls? Is it something physiological? That's a possibility. And if there's any palliative, and that's the benefit of my team, because I go out to facilities and I check in on patients in nursing homes. And we have a team on the inpatient side at Mercy. St. Luke's also has an inpatient team that does palliative care too. And we communicate, we share patients, because patients might use Mercy palliative care, but their hospital of choice is St. Luke's. So I'll reach out to the palliative care team and vice versa. They'll reach out to us because I might not know that a patient is inpatient at St. Luke's. Well, they'll call us. Hey, they're getting ready for discharge. Are you able to pick them back up? Because St. Luke's does see a few patients outpatient, but they're not as robust in the outpatient side as we are. And this, I don't know why they choose that, but that's their process. So trying to keep patients out of the ER, that's a big team focus of ours, and to see what's going on. And with dementia, is it more than likely it's a forgetting that they can't get up without assistance and they can't process to call for help. And then we try to find different components or speak with the nursing staff at the facility to say, hey, I'm not being accusatory, but let's figure this out. Like we got to stop them, keep them from falling. Do they need to move their room closer to the nurse's station? Do we need to get them a low bed? So we can't stop them getting out of bed all the time, but we can stop them from falling by giving them a low bed, so they decrease the distance of falling. So that's what I would recommend as well. But I encounter that daily, and those are the conversations I have with facilities and families and loved ones. And it's kind of a running joke every time I have to go and introduce myself to my dementia patients because they don't remember I was there. So it's a whole brand new visit every time I go, once or twice a month. And most of them are very pleasant and welcoming, and some ask, who are you? And I do get confused for sons, and I don't change that process. I just smile and behind my mask and support them as much as I can. Are there any other comments or questions or concerns or experiences that I can help with or have sidebar conversations with?
So, hi, Chad, this is Heather.
Yes.
In a different room from the church, but wanted to say a big thank you to you. In the process of ministry. I think, some of these last conversations and some of what you've been talking about is how you are there not only for the patient, but to help the family understand the process of dying.
Yeah.
And I think so many of us don't have that day-to-day experience, don't know what, oh, this is happening, this is normal, and so many times I hear families say, oh, the hospice, somebody from hospice, somebody from palliative care came by. And once we knew that this was normal, it made us feel so much better.
Right.
So thank you for that. I have a question for you though.
Yeah.
I'm going to put you on the spot.
Sure.
You've been talking about other people. I would think that this would be a very hard or a very weighty thing for you to be dealing with on a day-to-day basis, helping people navigate these times in their lives. How do you, I guess, keep yourself in a spiritually healthy place, an emotionally healthy place?
Yeah, that's a good question. This job, it takes the right, we're a small team, there's 4 nurse practitioners, there's hospice, because I do hospice too. And the team that we have, you have to go in as a collaborative approach. And you talk about supporting families, and having gone through this personally, because I've lost both parents to hospice. My dad died 20 years ago to cancer, and he was in hospice. and my mom had dementia and she was in hospice. So two completely different hospice encounters and realms. But having gone through that personally has really made it comfortable professionally. And I'm helping patients at ease and in this new chapter of life is what I call it. And a lot of times, well, I was reiterating back what I said, we listen to the patient. The patient's going to tell us what to do. They don't have to verbally tell us, but they'll physically and emotionally and spiritually tell us either it's time or we're changing and we need to have a different discussion. We call it goals of care. And everybody's on their own journey. And I don't want to say, a lot of the time the patient might be ready for hospice. They're accepting of their diagnosis, but the family is not. And that takes some time, and we don't force anybody. They have to process that themselves. And sometimes, like I said, not saying anything or not doing anything is sometimes the best thing. Because I've sat there and held hands, and I've gotten teary-eyed. I admit it. You can't not bottle up your emotions, because I've came to know some patients really well, and their disease process is starting to get the best of them. And maybe the patient and I are totally on board, and him or her and I are totally in tune, but the wife or the sister or the daughter has not fully grasped this yet. So the patient and I bring them along, and we don't force anybody, and it's all about wordsmithing. And it sounds as a bad adage, but sometimes I have to turn into a used car salesman, because I'm trying to sell a not very well running car to a family member, and to sell that idea of hospice, and it's going to benefit you. And I've had this occasion multiple times where I'm rounding out at the hospice house, which is a 12-bed facility out on Boyson Road, off of Blair's Ferry Road. And patients can go out there for respite during the month, or if their symptoms aren't able to be managed at home in a comforting way, they go to the hospice house, either for a short stay or for end-of-life processes. And when I round with a social worker and the chaplain. And we have some well-experienced chaplains. And to the point of, end-of-life process, they're okay. They're squared away. They've got the right medications on board. Their symptoms are managed, and they may or may not be cognitively with it, awake. They might be headed towards unresponsiveness, but I see the chaplain doing a lot of work, and that's comforting to me. And I've sat on the couch with my arm around a daughter while Bill, the chaplain, sat with the patient, and they said the Lord's Prayer together, and just the chaplain, and the chaplain's leading rounds on that point, and I just take a step back, and that's okay, because I do grieve, and I get these patients I get connected to, but I don't have the emotional, I don't have the 30-year family connection with these patients, so that's where I'm able to, I guess, disconnect, and I get home and see my family, and that brings me comfort, and it's reassuring. It's not stressful. It's a good thing, because I'm on a different realm of, I didn't fix their CHF. I made them comfortable, and they had a very comfortable passing. They were at home with their loved ones, with what
they wanted.
And they passed pain-free and were not in distress. So that's kind of how I deal with that on a day-to-day basis.
So when you said Chaplain Bill, is that Bill Warhover?
Yes.
Yes, he's fabulous. So for anyone who's on this call, Bill is a Presbyterian pastor, actually.
Yes, he is.
And a fabulous man.
He is. And he's done some really good work. And there's a few the other guys out there too for chaplain services. And Bill's predominantly assigned to the hospice house, so I interact with him a lot. And his wife,
Donna.
Donna, they run a community farm out by Mount Vernon. And that's their other, Bill works part-time, and their other side business is they raise vegetables and sell them for profit sharing and stuff. And that's just, he's just a unique man and brings the whole gamut of spirituality and healthcare to light. And that's, I've learned a lot from him, and he's older. So, you know, kind of a mentor to me as a and a person. He's just a good guy. So.
Yeah. Yeah, I would highly recommend their CSA shares. We've had some of those over a few summers. Really good produce.
But
now we're off topic.
It is topic, but humorous. So I went out and helped him pour cement last summer, probably the hottest day of the year. It was in July. So there was Bill and myself and a few of his CSA staff and a handful of retired Presbyterian pastors. And I don't know if you've ever poured concrete, but it's kind of a blue collar work. And I struggled to not curse for 4 hours in front of all of these pastors while trying to pour concrete on the hottest day of the summer. So
we probably have time for maybe one more question.
Yeah. Anybody else have any concerns or comments? Or
Chad, how
yes,
how have you evolved through the COVID crisis with having family members close to their loved ones that are leaving them?
Yeah, some facility. I was talking to Matt earlier. You know, the nursing homes, the traditional nursing homes, those patients are needing a higher level of care, and the family can't get in to see them, or they can see them through the window. They allow me to go in as a provider with I double up on my PPE, and I either call them on the phone while I'm in the room, I FaceTime them while I'm in the room, or and pre-COVID, you know, the family member who has dementia, who may or may not know their loved one, I would go see them, and then I would call the daughter or the son or the wife and say, hey, I stopped by and saw mom or dad today, and they're doing really well. That was pre-COVID. I'm still doing that post-COVID and current COVID. I was telling Matt, the patients that I see struggle are these tweeners that are like living at a meth wick in assisted living, where they're pretty independent, but yet they're on lockdown and their family can't come in. So those are the ones that are really isolated, and I try to get out there and see them more frequently. I may not be managing anything medically, but I'm emotionally supporting them, and that's okay. And I just try to get out and see them as much as I can and communicate with the families, and I do a lot of listening, and that's okay. And that's been difficult. But facilities have been pretty savvy with trying to get, you know, with the plexiglass but having mom with mild dementia sit behind a plexiglass and not able to hug her daughter, that's heart-wrenching. And I've battled with facilities, you know, mom's 94 with mild to moderate dementia, and she's still independent. And they're like, oh, we can't have her get COVID. Well, I would rather have her hug her daughter than get COVID. I think that trumps that, but that's fallen on deaf ears at times. So, because their, safety and infection control is that healthcare guidance direction is focused on more than what's best for the patient. Hanging out with mom and giving her hugs and back rubs and doing her nails with their daughter is more important than trying to prevent, COVID spread. So that's my soapbox. I'm getting off of that. So, but
hey, thanks.
Any other?
Maybe one really quick question. We really do have a hard stop with the church. Or maybe not. Maybe we should just wrap it up here.
Okay.
Because hey, thanks very much, Chad, for talking with us today.
And a little free marketing. If anybody needs support or has a loved one that needs support, have the church get a hold of me. I go into homes. I have a clinic. I see patients in the clinic. We have a team in the hospital. Even if you're in the St. Luke system, I can reach out to them. And if you're not connected with palliative care, I can hook you up and put a phone call in. And I go to all facilities. So we, in the Cedar Rapids area, I go to Williamsburg, to Anamosa, down to Coralville, clear out to Clarence. So
Mm.
Wow. Hey, thanks, Chad.
yeah,
We are, the Insight class will go on its traditional Christmas pause the next few weeks. And then on the second Sunday of January, Gary Connors Bow is going to start a series on the Apostle Paul. So that should be really, really interesting. So I hope you all come back for that. I think you have just enough time to get some coffee and join the church live stream. So we'll end it there. But again, thanks very much, Chad.
Thank you.
thank you. Thanks, guys. Appreciate it.
Thank you, Chad. Thanks,
Yeah.
Matt.